Hello, and thank you for joining us on this webinar today. 30 Minutes on Cellulitis and Soft Tissue Infections is brought to you by VisualDx. I'm Annie Sullivan, and I will be today's webinar moderator. Please now direct your attention to Dr. Noah Kraft.
Hello, everybody. This is Noah Kraft, based out in Los Angeles. I hope everyone can hear me okay. Just a reminder to everyone, if you could mute yourself. Most of you, I think, will be muted centrally, but if you hear a lot of scratching, try to mute your phones for those of you that are walking around. Hopefully everyone can hear me okay. If you don't, please text the moderator. Great. So let's get started. You can see my title slide on the PowerPoint, the title Red Skin, What Can It Be and What Should I Do? So, you know, this is a very perplexing problem. It's a very common problem. And so what we're going to do today is talk about the differential diagnosis, or all the different possibilities for red skin and how it can relate to infection, and how to use VisualDx as a tool to help you through that problem. So this is a typical case, a 37-year-old woman with diabetes and bilateral red skin of the legs. She's taken to the emergency room. And this is the clinician's problem: is what could this be? What does she have, and what should I do? So shown here is a typical case of this woman, bilateral redness of the legs. You can even see someone drew a line around it that they're suspicious of cellulitis. So this is a problem. How do we diagnose this patient? And it's an important one, because the ramifications of getting it right and getting it wrong have important consequences for the patient. So we're going to go through some cases, and then we'll go through the differential diagnosis, and then there'll be plenty of time for questions. So let's start with a case. This is Mrs. Jones. The question is, she came to the emergency room. She presented to the primary care physician first with acute onset of redness of the lower legs, edema. You can see blisters of the legs and some discomfort. And her primary care doctor diagnosed it as early cellulitis, gave her a cephalosporin, and then after 2 days at home, there was no improvement. So this is a really common problem. So should we admit her to the hospital, or should we discharge her? So when she comes back to the emergency room 5 days later, she really hasn't improved. And so the emergency room doctors think she has cellulitis. She's had it several times on prior occasions. So she was admitted for presumed community-acquired MRSA cellulitis. IV vancomycin was started, and she was admitted for continued IV therapy. She spent 5 days in the hospital and didn't get much better. And so we studied this a lot in our hospital and in several hospitals, and I'm going to talk to you about that. But this is a really common problem, and when you look at this slide, as we're going through this talk, I want you to think about what are the possibilities for what this diagnosis could be, and how you would sift through those different possibilities. First, as we get started, let's start with a quick quiz. Obviously, we're not going to check your answers, but I'm going to go through 5 quick slides, and I want you to look at the slide and see how you go through your differential diagnosis process and what you think it is. So here's case 1. And in the beginning, I'm not going to tell you much about the case. I just want you to look at these images and see just how challenging it is to diagnose these patients. Here's case 1. Here's case 2. They're going to go very quickly. Here's case 3. So you can see the variability in the types of redness, the location of the redness. Here's case 4. And here's case 5. So admittedly, I'm giving you very tough cases, and I'm not giving you other information, but this is to illustrate just how challenging it can be to diagnose these things. So by the end of this presentation, I'm hoping that you'll take away some important messages. One is you'll know some of the negative outcomes of misdiagnosis of cellulitis. You'll also be able to describe stasis dermatitis, the most common mimicker of cellulitis. You'll be able to describe some of the key findings of cellulitis, and then you'll know more of the common conditions of differential diagnosis of the red leg. So one of the important questions that people always ask us is, well, what if I miss a cellulitis and send the patient home? And that's really important. So what this graph shows you is the appropriate level of false positives. So you need to be sensitive to the fact that if you underdiagnose cellulitis, you could be sending a patient home with a serious infection that could lead to sepsis or even death. So you do have to be careful about that. But the goal is to get that green square to be not too big and not too small, or the green triangle. And what we mean by that is to have an increased accuracy across the board of cellulitis. This next slide that I'm showing you are the results of our study that was done in Los Angeles and in Rochester, New York, where we demonstrated 28% of all admissions for cellulitis were misdiagnosed. And that study was duplicated in the UK, where 33% of nearly 600 cases were misdiagnosed. So this means essentially 1 in every 3 patients that admitted to the hospital with cellulitis is not cellulitis. And this slide is that very first case I showed you. It's a patient that was admitted for IV antibiotics for cellulitis, and she had been admitted 3 times over a 6-month period, receiving IV antibiotics, daptomycin, vancomycin, and eventually dermatology and infectious disease were called. She was biopsied, and this is a case of paniculitis. So this is not an acute bacterial infection. This is an inflammatory problem. And the most important message that you'll hear from this slide and from the presentation in general is that cellulitis is almost never bilateral. So you really, if you're looking at a patient with bilateral redness of the legs, then that is almost never cellulitis. So that's important point number 1. One of the other important things is that there are many negative outcomes associated with misdiagnosis. Some of these will be obvious to you. What you're looking at here is a case of C. difficile. And so admitting patients to the hospital when they don't need to be admitted, some of the important negative outcomes are you can get hospital-acquired infections or nosocomial infections. They get unnecessary antibiotics. And shown here is a patient who was admitted for cellulitis, received unnecessary antibiotics, and developed Stevens-Johnson syndrome secondary to those antibiotics. So a very sick patient who never needed to be in the hospital in the first place. The economic burden I'll spend a little bit of time on just to generalize how important each and every diagnosis is. So each patient that's admitted to the hospital with an accurate or a misdiagnosis for cellulitis costs about $12,000 per patient. So if you multiply that out and assume a conservative error rate of 20%, multiply by that by the number of admissions in the country for cellulitis, this one misdiagnosis just for this one error is about $1.4 billion. And that doesn't account for unnecessary antibiotics, cost to the patients, lost revenue, et cetera. So a really important problem nationally, internationally, and one that you can address one by one by improving your accuracy. So let's go through the quiz answers, and then we'll get into some cases and about the differentials of these things. So this first case is actually bilateral stasis dermatitis. So most important message, if the redness is bilateral, it's almost never cellulitis. And in this case, even though there are blisters, you can see the chronic scale and the redness bilaterally, and this is stasis dermatitis. Case 2 is pretibial myxedema. I'm only showing you one leg here. The other leg is a little bit edematous as well. This would have lasted many, many weeks or months to get to this stage, so that's not cellulitis. But each of these cases was a case of misdiagnosis of cellulitis. This case is paniculitis, and so this case I'm only showing you one spot, but there would be multiple tender erythematous nodules or plaques on this patient. This is a case of contact dermatitis. It started as a bug bite, and then the patient was applying neosporin chronically, and you can see how it's almost eczematous looking around the edges. And this final case is true cellulitis. So you can see how difficult it is to really tell the difference just by looking at these things. And so what we're going to talk about for the rest of the presentation is how you can hopefully differentiate between these things and some of the factors that could help you. So let's go back to Mrs. Jones. As you can guess from my comments about how cellulitis is never bilateral, Mrs. Jones never had cellulitis. So she had prior admissions for cellulitis, and this is acute stasis dermatitis, bilateral legs. Even with bulla, you can see that she's obese, she had diabetes, and this is acute stasis dermatitis. It's somewhat scary, and it's hard to get used to knowing stasis dermatitis, but these really can mimic infection. And if you ask dermatologists or infectious disease, the idea of bilateral cellulitis really just doesn't exist. This is Mrs. Jones a few months later. You can see she has now changes of chronic stasis changes. And now what I'm going to show you is how you can use the VisualDx tool to go through cases. I'm showing you a few PowerPoint slides, but I'm going to be toggling back and forth between the live system, VisualDx, and the actual PowerPoint. So you're looking at a PowerPoint still. Most of the attendees on the call have access to VisualDx. So if you are on the differential diagnosis builder, you'll see there's a special area for cellulitis differential here in the special clinical scenarios. The next slide is once you're inside the builder, what I'm showing you here, and we'll go through some specific examples, but why this is so easy and so important to do is you can see over here I've entered just two things, bilateral and leg, and within 5 seconds you can get a nice differential of red leg, bilateral, and you can see that cellulitis is not even in the differential of bilateral leg redness. Here I've done the same thing except I've chosen unilateral and the patient has a fever, and again within 5 seconds you can get a nice differential for redness of one leg in a patient with a fever. And here you can see now there are a lot more infectious causes of the redness of the legs. So let's talk about how to recognize stasis dermatitis. This is that first case I showed you in the quiz, and there's some important key components to recognizing stasis dermatitis. One thing is it's really common. So stasis dermatitis is definitely a horse, it's not a zebra, and it represented about 37% of the misdiagnoses for cellulitis were actually stasis dermatitis. It's very common to mimic cellulitis. It can have bullae, drainage, and crusting just like other things, and it can mimic an infection. So here are some examples of cases of stasis dermatitis with some points to highlight. So stasis derm tends to move more slowly than cellulitis, so it evolves over days and weeks as opposed to hours and days. In this case, you can see it frequently has vesicles and bullae. It usually doesn't ascend, so it's usually quite localized. And all these cases I'm showing you are misdiagnosed as cellulitis, but these are all stasis dermatitis. So you can see how this is very well localized. It's not ascending. Here you can see some signs of venous incompetence that are common in stasis dermatitis. You see the blood vessels and enlarged varicosities in the background. You can see signs of chronicity, such as scaly plaques shown here. Sometimes it can even ulcerate. It can be tender, so after you have bullae, it can turn into erosions and ulcer. This is chronic stasis dermatitis bilaterally. And it's often very chronic, so it can go on, and it's just important to remember that cellulitis just does not present bilaterally. So sometimes under the redness, you can see papules and signs of chronic lymphedema, as shown here. And so key teaching point number one is the point I keep reiterating, and I want you to take it home, is that cellulitis is almost never bilateral. All of these cases I'm showing you, these were admitted to the hospital as cellulitis or infection, and none of them were an infection. So one of the important things is knowing the therapy of stasis dermatitis. So if you have diagnosed stasis dermatitis, it's quite easy to fix it quickly, and the patient does not need to be admitted to the hospital. So the most important things are make sure the patient's not putting on any other topical creams such as Neosporin or bacitracin. Those often lead to contact dermatitis. And generally, you need to use mid or strong potency topical steroids like triamcinolone, fluocinolone, elevate the legs, and compression stocking. For milder cases, you can use mid-potency things like triamcinolone The most important thing is to get the patient to keep their legs up and get the swelling down. And so while stasis dermatitis can be unilateral or bilateral, cellulitis, this is a case of cellulitis, is usually unilateral and can present with the streaking, the ascending of the erythema, that type of thing. So let's move on to how to recognize true cellulitis. So this is a case of a patient with actual cellulitis. You can see how the erythema is very acute. There's no scale, and you can see someone's drawn a pen line around this, but this would ascend very quickly over a period of hours to days. Here's another example. You can see that the erythema is spreading from the original site of trauma to the surrounding area. So this is very quickly moving erythema. Here's another example. And so before I go on to talk about the histories, the factors that suggest cellulitis, let me toggle over to show you some examples of how you might use VisualDx to handle some of these cases. So this is the home page, and if you're looking to help with cellulitis, go to the differential builder button, and then down here, as I showed you, there's a button that says cellulitis differential diagnosis. So if you click on this, it walks you through a very quick process where you can just click two things. One is the body area, so if you click leg, and then is it one leg or two, and does the patient have a fever, and click continue. So you see it took about 5 seconds, and now I'm showing you the differential diagnosis for the bilateral red leg. And then you can go in and you can look at these different types of diagnoses. So you can see there's contact dermatitis. If you want to look at any of these, you can click into the All Images view and scroll through the different cases of contact dermatitis. If you click on any of the images, it will show you a high-resolution view. And then you can look at the other things that are really common, like stasis dermatitis. The other thing you can do is you can read about the diagnosis, look at the differential diagnosis for that disease itself. Here you can see I'm looking at stasis dermatitis. The best test to do, management pearls, and then there's good extensive therapy recommendations, which topical medications to use, and other tips about compressive leg stockings, the strength of them, etc. The most important thing about using this system when you're concerned about a skin or soft tissue infection is that it doesn't focus you in on the right diagnosis, it puts the right diagnosis in your differential. So if you forgot about vasculitis or Sweet syndrome or pretibial myxedema, some of these cases that we're going to talk about, you can quickly look through these and compare it to your patient, and you can see risk factors for this. So I'm going to show you one other quick example, and then we'll get back to the presentation of PowerPoint. I'm going to go back to the cellulitis differential, and instead of choosing bilateral, now I'm going to choose unilateral and say the patient has a fever and click continue. And now look at how different this differential diagnosis is compared to the one I just showed you. So now because the patient has a fever and it's a localized unilateral process, you get abscess, cellulitis, other infections that are more common with that presentation. So let me go back to the PowerPoint and we'll review some of the factors involved in cellulitis and then some of the most common mimickers. So if a patient has cellulitis, they're much more likely to have rapidly ascending erythema and swelling, proximal lymphangitic spread, tenderness. They're more common to have a fever, and it's usually acute, so recurrent cellulitis is also less common. Patients with cellulitis, if you have them in the emergency room, they're also much more likely to have a leukocytosis. And so these are the big differentiating points between cellulitis and stasis dermatitis here. So cellulitis, you often have a history of trauma or a bug bite or some injury. It's usually unilateral, it's usually acute, there can be a fever, and there's commonly a leukocytosis. As opposed to stasis dermatitis, where it can be either unilateral or bilateral, there's usually signs of chronicity like scaling and dry skin. It's commonly recurrent, and as it gets more recurrent, hyperpigmentation can occur. So as we wrap up the presentation, I'm going to go through some of the most common mimickers of cellulitis. As I mentioned, the most common is stasis dermatitis, but there are many other things in the differential. So here are a list of some of the most common things in the differential diagnosis for red skin, and we're going to go through some of these. So here's an example of contact dermatitis, and contact dermatitis is almost universally itchy, and you can ask the patient about neomycin, lanolin, topical diphenhydramine, other things they're putting on the skin. Here's an example of a fixed drug eruption that's commonly misdiagnosed as cellulitis. This occurs after a patient takes commonly prescribed or even over-the-counter drugs, and you can see it has a dusky center and is quite round or oval. This is a case of paniculitis. You can see it's multifocal, and it has this orange or orange-brown hue to it. But things that are multifocal or bilateral, these are almost never cellulitis. This is a case of a patient with a DVT, and this is a common thing that you need to rule out in patients that have red legs. And DVT usually presents simply with unilateral edema and no redness. So if a patient has bright red skin, it's almost never a DVT. Here's a case of vasculitis where you can see it's got some almost scarred-looking atrophic patches in the middle of it, and this is usually quite painful. Occasionally you can have bullae. Here's a case of acute lymphedema, and this commonly mimics cellulitis as well. This is kind of a variant of stasis dermatitis. Here's an example of arthropod or bug bite reaction. So commonly right after a bug bite, you get a very quick urticarial pattern around the bug bite. You can see here the bug bite's in the center, and this is an urticarial wheel around the bug bite. It can be quite frightening, but develops very quickly. Herpes zoster, usually unilateral, quite painful, but you see these grouped vesicles in a dermatome pattern. Most of you are probably very familiar with this. Here's another case of herpes zoster going all the way down the foot. You see these grouped vesicles, dermatomal pattern. Meioki's granuloma is a deep fungal, a fungal infection caused by dermatophytes, but it's gone down into hair follicles. And again, this will be much more chronic. You can see it doesn't have that bland erythema in between the hair follicles that are infected. Here's a case of tinea corporis. You can see the redness. It's crossed right across the thigh here, and much more chronic. You see the changes of scale, but again, easy to misdiagnose as cellulitis if you don't have a good history. Lyme disease. So Lyme disease is commonly very difficult to discern if you just look at it. But this patient would have developed this slowly spreading erythematous patch over a period of days to weeks as opposed to hours to days. And finally, just show you some of the complications. This is true cellulitis. So this is an infection after trauma to the palm. This patient had a palm thorn stuck in their palm. And then you can see this lymphangitic erythema spreading up the hand. So this is true cellulitis, would need IV antibiotics. And then some of the important things to watch for, in addition to sepsis, and to make sure you're really tuned to patients that could develop a systemic infection and sepsis, are necrotizing fasciitis. And the easiest way to tell necrotizing fasciitis is that the pain of the exam is usually wildly out of proportion to what you see. So this patient would be very, very tender to the touch. And it's important to know that necrotizing fasciitis is usually caused by streptococcal infections after skin trauma. So the take-home messages are, really know that there's a wide range of diagnosis of the red leg, and just to be aware of the enormous problem of overdiagnosis of cellulitis. The cellulitis is almost never bilateral. So if you're admitting a patient with bilateral redness of the legs, really think through if you think that's cellulitis, because it's probably not. And you should consider either using VisualDx to get help with your differential, or calling a dermatologist, infectious disease, someone who might be able to help you narrow down that differential to figure out what the bilateral redness is. In the differential for cellulitis, stasis derm is the #1 disease, often mistaken as cellulitis. And then an important feature about getting your diagnosis more accurate is to know what the complications and other serious diseases associated. So necrotizing fasciitis and sepsis, it's really important to recognize the early signs of those diseases. So I think I'll stop there. I can do some other examples using VisualDx, or I can also take any questions. But again, you can, in your own time, you can go through the cellulitis differential builder and then review some of these pictures of the other diseases that mimic it. So we talked about most of the common things that are in here, like Lyme disease, zoster, cellulitis, etc. And you can play around with VisualDx to really get a better handle for what the differential of the red leg is. So I think I'll stop there and take any questions.
Thank you, Dr. Kraft. I will now moderate the Q&A session. We can give the attendees a couple minutes to formulate their questions, and maybe in the meantime, you want to talk a little bit about the cellulitis program at the University of Rochester?
Sure, that's a great idea. Let's see if I can open a new window here. So because of this big problem that we studied of misdiagnosis of cellulitis, in the city of Rochester, there's an implementation program into the 4 major hospitals where we're trying to improve the accuracy of cellulitis diagnosis. And the program consists of 3 parts. One is you take a CME, a 15 to 20-minute CME course about this problem. And then you have access to the VisualDx differential builder. And then there's also a follow-on program where patients can be referred to a local dermatologist within 24 hours for patients that are going to be discharged. So if you're interested in this, there's a website on visualdx.com about cellulitis and sepsis safety program. And you can see here's another graphic of just how big of a problem this is in the United States. And this is universally true. The hardest thing about this is to know when you don't know. So that's the hardest question, is when you're admitting a patient or you're thinking about cellulitis, when do you need help? You should know that when we study this in hospitals in New York, California, or England, that 20 to 30% of these patients being admitted don't have cellulitis. So every 3rd patient you admit, statistically, that would be a misdiagnosis. So really think it through when you're considering the admission for cellulitis. Could this be contact dermatitis? Could it be stasis dermatitis? And if people have specific questions about this program, you're welcome to email me offline, and I can explain it to you if you're interested in implementing it in your hospital as well. Here's my contact information. So if people have any questions, make sure you type them into the chat window, or you can also tweet them.
Dr. Kraft, we have a question for you. Suppose a patient undergoes incomplete treatment for cellulitis. What could be the outcome, and would the diagnosis criteria change? Great.
So that's a good question. So often, a lot of patients, they don't want to take pills, they don't want to take antibiotics, and in general, if you're confident about the diagnosis of cellulitis, you want to really encourage the patient to take the full course of antibiotics. If they're inpatient, it's easy, but when you send them home with oral antibiotics, that can be one of the complications. In general, the diagnosis criteria don't change. You'd still want, if the patient has cellulitis and they just took 1 day, for example, of antibiotics, you'd want to see them have rapidly ascending erythema, a white count. These are patients that would definitely be worth checking a CBC to see if they have a white count, and really encouraging them. All of this being said, it's very complicated because when you have a patient with stasis dermatitis, if you admit them to the hospital for cellulitis and you give them antibiotics and you put their legs up in bed, they'll start to get better as well. So the patient that you sent home with antibiotics, if they don't take the full course and they had stasis dermatitis, they'll get partially better just from putting their legs up as well. I guess the short or medium length answer is that the patients have the same diagnostic criteria after they've taken a short course, but you want to be even more careful to check a CBC and make sure you're not missing something serious.
Great, and we have another question. What's the difference between erysipelas versus cellulitis?
Great question. So if you're interested in that type of question, there's a great way to compare them so you can look at them side by side. And one of the ways that it's nice and easy to compare things side by side is to use these check boxes and this compare view. And so here are erysipelas and cellulitis of the leg, so you can compare these different pictures. Erysipelas, in general, it tends to be more painful, very well demarcated, and the plaques are slightly raised. So let's go in and look at some pictures of erysipelas. So you can see this would be a classic presentation of the border of erysipelas. So these are very painful red plaques that cross borders of anything and spread quite quickly. So this would have spread over a period of 2 or 3 days across this woman's face. And even here you can see the border of this. It's hard to tell, but these would be more raised. And erysipelas tends to be caused by streptococcal species. When you go back to the compare view, if you compare that to cellulitis, cellulitis is usually has a more ill-defined borders. It's not usually raised and is more commonly caused by staph. It's usually not quite as painful as erysipelas, but it's a great question because they're often hard to tell the difference between them. If you're not sure if something's erysipelas or cellulitis, you should make very sure that your coverage includes both strep and staph coverage. And some of the antibiotics don't cover both. So if you're concerned about erysipelas or a streptococcal infection, you want to make sure you have good penicillin or cephalosporin coverage for the strep.
Thank you. Another question. You said that cellulitis almost never presents bilaterally. Can you describe when it might present bilaterally?
So that is a good question. And the main thing that I wanted to mention about that is that when you think of a bilateral bacterial infection, the most common one is actually Vibrio vulnificus. And so I'm going to choose bilateral leg again. And you see down here at the bottom Vibrio vulnificus. So Vibrio is one of the few bacteria that usually, and it's a very aggressive infection, and it usually occurs after exposure to brackish water, like the post-Katrina situation where people were wading through water. There were 7 or 8 cases of Vibrio infection. It can be quite deadly, and so this is one of the infections you can see here. This is a classic case of Vibrio. It's more purpuric. There's bulla, and it's on both legs. So this is quite a deadly, very rapidly ascending infection. Cellulitis being bilateral, the only times that you should be concerned about that is if a patient had trauma to both legs simultaneously. You know, sometimes like walking through brush, or if you're doing construction work and you scratch things across both legs at the same time, you might develop infections in both legs simultaneously. I think where the confusion comes in are these patients who have, stasis dermatitis, and this commonly presents bilaterally. And then you get like patients like this patient here. This is often misdiagnosed as cellulitis because it's bilateral redness. But these are not infected legs. These are inflamed legs, and it's just important to know that difference between inflammation and infection. So when I say almost never, I mean mostly I'm talking about Vibrio vulnificus, and then the very rare patient that has trauma to both legs simultaneously.
Thank you, Dr. Kraft. I think that's all the questions that we have right now. Thank you to all the attendees who dialed in to be present for this webinar today. Here is Noah Kraft's contact information, and this presentation has been recorded and will be made available to you in the future.